my background, because I think it's important, because all of you are spending a precious time listening to me speak. And I feel it's very important um, to give you my credentials and to a little bit of assurance as well as to where I'm coming from and why you should hear myself or people like myself speak on a topic, a topic which you see clinically and I see clinically as well in my practice. And why should that be? Why should you actually spend this time listening to me? And as a reason for that, I thought I'd give you a little bit about my background as to what makes me hopefully an expert or a recognized around the world on certain topics. And it kind of really goes back to approximately over 25 years at King's College London. And I've been there for quite a while, and I've kind of taught undergraduates there. I started teaching undergraduate dentists, and then I started postgraduate programs there and teaching postgraduate dentists. And currently I don't do any undergraduate training or teaching, but I do a lot of postgraduate teaching and research. I have a PhD student, a few PhD students who I supervise, and they're doing various projects. I run a master's aesthetics course. It's a master's from King's College London in aesthetic dentistry, where all my students in their final year do some MSc research projects in different areas in aesthetic dentistry related to the topic. And I'm also a lead of practice-based research. In other words, I do have an academic background whereby I have looked at different aspects of the research and also conduct it myself. So it gives me a sort of a little bit of a knowledge, a little bit of a head start, if you like, on the background of the problem, which I think is important to have. And that's one area that I do a lot of, and I, of course, still do it. It's based at King's College University, and our faculty, the dental school at King's College London, has just been voted #1 in the world, and it's quite a big organization. But it's quite an honor to be part of it, and that's where I've done my academic training myself, as well as teaching experience. So I think it's important, whenever you look at something, that you are looking for credentials of people who do have a grasp on the literature and the research, as well as the clinical, of course, because we're all seeing patients, aren't we? It's all very well reading papers and doing research and so on, which is an important component of how we kind of treat our patients. But primarily, you're looking for someone who also does it for a living. And this is a little snapshot of me in my practice in London, in the UK. And I have been in this practice ever since I qualified. I did my undergraduate training, incidentally, in Newcastle upon Tyne, which is north of the border here. Well, not also north of the border. It's not in Scotland, but it's close. It's further down. It is in England. And I did my undergraduate training there, and I qualified around about 1987. And I came straight to this practice, and I've been there ever since. Now, the reason I'm sharing that with you is because I've kind of had the honor of treating my patients, and now their children, and now their grandchildren. And indeed, I've also kind of seen my work over the last 30 years or so. So it's a nice combination to have, where you're doing the research and you're kind of seeing what kind of things that perhaps work in theory or supposed to work in theory. And then when you translate it into practice, to actually see whether or not it is translating. Both, if I may say so, in an economic sense, because we have to be pragmatic in practice. You all are practitioners, I'm sure. It has to be pragmatic and applicable to our patient population, as well as working. So I've had the sort of honor to actually look at my work and document my work over a period of time to see what works and what doesn't work. And I have to say, it's in my humble opinion, my practice has been my educator. My own patients have taught me about things that work or don't work. And I'm going to share some of my own clinical cases that I've treated in practice with you today on this topic. So you're able to kind of see how things behave over a period of time and how the rationale for what I'm saying to you works. Okay. And so that's my sort of background of academic and clinical. And on the basis of that, of course, I launched the Academy of Dental Excellence approximately 7 or 8 years ago. Because there was a need, I felt, that, of course, people come to be educated at university at postgraduate level, and of course, specialist level. But there was a need amongst general practitioners who I meet throughout the world. I've been very lucky in that context because I have taught around the world, to actually have a structured training in their postgraduate field so that they're able to see a lot of patients and treat your patients. And so that's why I kind of started the Academy of Dental Excellence, where essentially we are, got a faculty of people from all around the world. People I've kind of handpicked throughout the world and contribute to the content. And we formed this academy. And it really is to actually train postgraduate dentists who are general practitioners and really bringing up the skills level up. So that's where my background is and why I feel I'm kind of qualified to speak on certain topics and how I've designed. So this is like the King's College program in MSc aesthetic dentistry is something that I developed along with their prosthodontic program. And I've kind of taken those skills and put it into a sort of a academy of my own, whereby I've kind of designed the courses myself. And we'll talk about this a little bit later regarding the diploma. So I've done a lot of research on toothware, and I looked at it for several years along with colleagues of mine. And I've published extensively in peer-reviewed journals, international journals. And what that really means is that, when you write something or do some research, your colleagues actually are able to critically appraise the research that you do and see the relevance and before it gets published. And part of what we are going to discuss today is very much also dependent on occlusion. Now, occlusion is a topic which can be quite daunting sometimes, but I'm going to sort of focus a little bit on it to address the problem that I'm going to present to you, because I do believe a good understanding is important. So toothware and occlusion kind of go hand in hand, I feel. And so I wrote along with Shamir. You see my colleague here, Shamir. He's the deputy director of my program in MSc Dentistry. He's also part of the academy as well. And he is doing a lot of research himself at the moment, and we work together, and we've published together in numerous journals. So we've published there on occlusion as well as toothware itself. As it happens, the work we've published on toothware is kind of required reading for all universities around the world. The British Dental Journal informs me that the series that we wrote on toothware, this 4-part series, is kind of the most downloaded papers in their background history, and it's kind of required reading for all postgraduate programs around the world. So I've looked at this problem in detail, and what I'm going to do today is really share with you the information and experience that I have relating to this particular issue. Along with the articles that I write and the research, I was also very privileged and honored to be part of a European expert panel on toothware and severe toothware. And some of the information that I'm going to share with you today is something that we decided upon and published. And the other thing that I did very recently, in fact, it was just published in January, is this book on management of toothware. And along with Shamir Nick Opdam and Bas. Professor Opdam, Professor Lumens are from the Netherlands, and I published this book. So that's the kind of the research that I've done on this topic, and we're going to share together. So what is this kind of a consensus meeting? Basically, a consensus meeting is where you have invited a group of experts in a particular topic. For example, in this particular case, it was tooth wear, and you basically put this expert panel into a room in a hotel. You feed them a little bit. There's a bit of food and water, so you keep them alive. And so you keep these experts all around, and you basically ask them to make a decision on certain issues of that topic. And until you kind of decide on a few outcomes, you're not let out of the room, basically. They feed and clothe you, and then you have to come up with some sort of framework by which you arrive at certain decisions regarding a topic. So here you see a sort of a combination of, that's Professor Opdam there, that's Professor Lumens, this is Professor Bartlett, that's me and Shamir Westseller, and quite a few. That's Goran Benek is doing some very interesting work with ceramics in Switzerland. So we're sort of put in this room, and basically we're not allowed out until we decide upon certain outcomes. So that's the consensus meeting, and what I've tried to do today is actually bring out from that consensus meetings the bits that are relevant clinically when we look at our patients for this particular problem, okay? So a lot of what I'm going to say is quite recent. This was published in the Journal of Adhesive Dentistry in 2017. So you're getting quite a recent view on this topic, and particularly related to localized tooth wear, as I will define for you. So the first thing we thought we'd define in this is the definitions, is what physiological tooth wear is. Now, one of the things that I do on my courses, and those of you who will hopefully join the diploma will also be acquainted to, is that you need to look at certain definitions, and you need to actually be able to analyze some of the research critically, so that you can apply it for your patients. Because I've always found in research, it's all very well doing some research in an ivory tower and breaking things in the laboratory and joining them in again, or doing it on animals and so on. But you have to really be confident before you try it on your patients, because that's your bread and butter. That's my bread and butter. So I don't want to be using my patients as guinea pigs. I don't want to be using them as a research. I've got a private practice. It's a very precious private practice. And I want to be very aware of what I'm going to do for my patients. And so you need to develop a little bit of a critical eye when you're looking at the evidence. So for example, let's take this definition of physiological tooth wear. We've come up with these figures. I hope you can see about a 60-year span, and we've come up with some figures. Now, what's interesting, I think, that which I hope you can appreciate, that you saw a group of what I said was European experts joined together in that room in Nijmegen. Well, physiological tooth wear might be very different in your locality, in Mumbai, in India, or in Africa, or in Australia. It must be very different. And so the first things that we were actually muscling about is that, well, this physiological tooth wear says who and to which population, okay? And this was an area of debate. And I just thought I wanted to throw some light on it for you, because of course, you will actually see tooth wear in India, for example, in your community of patients. And you will say, well, actually, Sabir, my tooth wear patients are a lot more than that, I think. These figures you've come up with is very conservative, perhaps, and it may be true. But I think it's good to actually look at the literature and be able to analyze the evidence so that you can apply it. And that's what we're going to do gradually as we look at this particular problem that we have today, okay, that we're going to discuss today. So if you know physiological tooth wear, then of course you need to know what pathological tooth wear is, okay? And this is a very difficult area of what you define as pathological tooth wear, okay? Because where do you start and where do you stop? For what's pathology for one person might not be for another in this scenario for tooth wear. And one of the definitions we came up was, well, actually, if you've got tooth wear, which is causing pain, discomfort, functional problems, or deterioration in the aesthetic appearance, and if it's progressing and is atypical for the age of the patient, then it's defined as pathological. And what I want you to do is, with these definitions, is to immediately apply it into your practice, or the patients that you see day to day in your practice, and see how this kind of works. So what we're saying here is that you have a patient in the chair and you notice some worn teeth, and then you have to ask yourself the question, is it causing the patient pain? Is it causing discomfort? Are there any functional problems? Is the patient complaining about aesthetics because the teeth are actually worn down? Okay, and is it progressing? Okay, these are the questions that you would ask yourself. And the other thing that's quite important is that, is it progressing in a way which you think that if you tackle this problem in a few years down the line, the treatment would be much more complex than it perhaps what you could do to control it now? And of course, the age of the patient is important. Okay, how old is the patient? And if they're in an age group where they're showing uncharacteristic wear, then you would perhaps decide to intervene. So those were the two definitions, physiological and pathological. One extra bit of definition that we needed, I think, and which is very relevant to today's topic, is severe tooth wear. Now, this is something that we felt was distinctly different. And what I'd like you to now imagine is, when you're seeing a patient, and you're seeing a patient of a particular age, perhaps an adult patient, and you notice the teeth, and you notice one or maybe two or maybe a group of them worn down, but not the rest. Okay, and you kind of think about, where did this fit in? Is it pathological, physiological, rate, etc.? But we felt that it was important to identify this, because this is essentially very relevant to our topic today, where you see isolated teeth that have worn down. And we decided to define severe tooth wear as substantial loss of the tooth structure with significant loss of the clinical crown, more than a third. So if you're seeing a tooth now, not a sort of general dentition now, a tooth, and you see a third of the crown missing, for example, or worn down, then that would be classed as severe tooth wear. So it actually relates to the amount of tooth substance that is lost, okay? And it sort of focuses on that. So if we now just elaborate on that, the differentiating between pathological and severe is that severe relates to the amount, whereas pathological it relates to the nature, or the pattern, the time factor of tooth wear. Okay, so those are the main differences between the two when we're looking at it. And it's important to define the two, because that if we're going to we've got some extra people joining from Binsa. If you wouldn't mind just putting your mute on, Dr. Nias, that would be very useful. Thank you. And so we got this tooth wear as well as pathological tooth wear. And so one is to do with the amount, and the other one is to do with the rate. Now, let me just clarify that with you in certain examples. So let's see this case here, where essentially it's a tooth of an adolescent, okay? And the patient is complaining of sensitivity. So in other words, we go back to the definition, we do have a symptom of sensitivity, okay? But it's pathological only because it's to do with an adolescent. So this amount of enamel loss, if you like, in these areas is not usual for this age. And of course, there's a bit of sensitivity and therefore a symptom as well. But most of the crown is still there, okay? So it is not severe, it is pathological, okay? If we compare this to this patient here, who is 83 years old. Now, 83 years old, you would expect, if the teeth are rubbing together for vast majority of years, there will be some wear and tear. But in this patient, what we're seeing, in certain teeth, there is more than a third of the crown lost, okay? So for an 83-year-old, generally speaking, there is tooth wear, which we would expect for this age. But in addition, we have a severe tooth wear in a few areas, okay? So this is severe, but not pathological, all right? And then, of course, we have pathological and severe. So here we have a patient who has lost the rate and the amount of teeth are relevant here. And so therefore it's pathological and severe. And the reason why I'm kind of isolating this for you is that when you now imagine your patients and in your surgeries as how you would classify them and how you would sort of lay down a diagnosis perhaps, is to actually look at these terminologies, physiological, pathological, and severe, and basically identify what the patient actually fits in that. Because then what we'll do is only when you have the diagnosis, will you be able to do the treatment plan or the treatment for that case. And remember, one of the background nature of this is the presence of symptoms. Okay, it's sensitive, is there an aesthetic issue, is there a functional issue? And that's what you're going to look at. Or if you didn't intervene right now, would it make it too complex to deal with in the future? These are the factors that you would need to look at. And this actually is quite a bit more difficult question to answer than it first seems. And so for that reason, we also thought that we would actually develop a flow diagram to guide us through when or if treatment is required. Because a lot of the times you may have a patient, and you can identify, when I say this because I have patients like this, where you identify a problem, you have a diagnosis, but the patient does not want any treatment done. Okay, which is fine. It's the patient's prerogative and choice. However, you need to, as a clinician, be able to be prepared to explain to the patient of what are the possibilities and sequelae of leaving the things as you see them, or leaving a diagnosis or untreated. So the very first thing we thought we'd do would create this flow diagram. And if I talk you through this, is that they ask the question, is there any pathological treatment? Any in tooth wear, and is it physiological? If it's physiological and the answer is yes, then there's of course no treatment that's required. So in other words, there's no tooth wear. Any wear you're seeing is physiological. As an old patient, they're bound to actually have some worn teeth, and that's fine. If, however, you find that there is pathological severe tooth wear in the diagnosis, and the answer is yes, the next thing that is very important to do is to risk assess it and consider the etiological factors and document the amount of tooth wear. Now, we'll touch upon a little bit about document later on, but it is actually quite a contentious issue as to how you would document the amount of tooth wear. Okay, but the fact I think is important is that you at least identify it. In other words, you actually label it as pathological severe or pathological and severe. So you have a diagnosis present. And following that, of course, you can do your risk assessment and consider the etiological factors, which we will touch upon in a moment. And then the very next thing you do in your treatment plan is you have to prevent it. You have to have a prevention program with periodic reinforcement and counseling and monitoring. Okay, this is prerequisite, and this is quite a nice flow to have for your patients. In fact, when you're treating any disease. Okay. And then you ask yourself that crucial question after you instill that prevention program for your patients is the tooth wear a cause of concern for the patient or the clinician? So here what we're looking for is we're looking for symptoms and signs. Is it sensitive? Is there function problems? Is there aesthetic issues that the patient has brought out? So in other words, these are patient complaints or signs and symptoms, and we need to look at that. And the other aspect that we need to look at from a clinical point of view is even if the patient didn't have any concerns, do we as clinicians have any concerns for the amount of tooth wear? And here I would say it won't be towards an aesthetic issue, because the aesthetic issue is a very subjective one between the patient and what they think about what looks good. But as a clinician, where do you think, for example, a tooth is wearing down quite considerably, the nerves are becoming visible, the nerve areas become visible, and if you don't do something that is easy now, you may have a complex area in the future. And of course, the patient might disagree to have the treatment, which is absolutely fine, but at least you have documented that case, and you're coming from a point of information rather than coming as a surprise later on. Because I know perhaps in Mumbai it's not so active here, but in the UK there is a question of supervised neglect, which actually is suable by the patient, and the General Dental Council, who I do some work for, does look at that as an issue. So in other words, you're expected to diagnose the problem, inform the patient, and then if the patient wants the treatment, that's fine. If they don't, it's okay too. The important factor is that you did diagnose the problem and you made the patient aware. If you didn't, then that, as far as the General Dental Council is concerned, is negligent. So it's important for that. Now, if the answer to that question is no, so there's no patient concerns and you yourself do not have a issue, then you will basically stay within the prevention program and reinforcing the prevention aspects of it. If, however, the answer is yes, then you need to formulate an active treatment, perhaps a restorative treatment plan, which we'll touch on in just a moment, and established informed consent. You would do your restorative intervention, which we will touch upon in a moment, and then you will be back to prevention. So this flow diagram that I'm just showing you here is something that we came up with as a flow diagram which would be applicable in clinical practice, where essentially you would have your patients in your chair and you're able to make this decision-making process and rationalize it. And I thought this was important because tooth wear is one of those plain issues where sometimes a patient comes in with no apparent symptoms and you are diagnosing it, okay? So this gives us sort of a rough background as to when or not to intervene with your restorative options, which we'll touch on in a moment. The other aspect of looking at tooth wear is the etiology of it, of course, because you need to know where it's coming from before you can actually devise a effective prevention and management protocol. And here, what we have is that we felt that it's usual to actually divide tooth wear into attrition, abrasion, fraction, erosion, so on. But we thought that this classification would be much more suitable clinically. And to firstly actually look at the etiological factors and decide, is it the predominant factor, is it chemical or is it mechanical? And then once it's decided whether it's chemical, you look at if it's intrinsic, for example, extrinsic, that it's coming from outside, from diet, from an acidic diet, for example, or is it intrinsic? In other words, it's coming from some intrinsic source like GORD, that's gastroesophageal reflux disease, and if that's causing it, okay? And you look at that, and then what you need to sort of determine is which factor is the more important here. Similarly, mechanical, we look at extrinsic, is it coming from habits like nail biting, toothbrushing, etc., or is it intrinsic? Okay, and in that, there's bruxism, tooth-to-tooth contact that's causing it. We felt that looking at etiological factors from this perspective would be much more useful clinically rather than the customary erosion, abrasion, etc., etc., etc. And generally speaking, what we always find is that tooth wear has a multifactorial etiology. Okay, it might have a more predominant component, mostly erosive perhaps, but it is multifactorial. So when you prevent your tooth wear issue, you need to think a little bit outside the box, if you like, where you're looking at multiple factors which are contributing to the problem, and you need to control each one of them in your prevention plan. In the prevention strategy of your tooth wear case, whether it be localized or in fact generalized for this matter, I just thought I'd pick out some highlights of your prevention strategy, some of which are perhaps obvious and some are perhaps maybe come new to you. And what we found when we looked at prevention strategies is that the daily frequency of acid intake was important. So if someone was having acid intake daily, that is a very contributory factor for tooth wear, okay? The other thing that we felt was that if you had fruit intake or acidic intake with meals, then it's not associated with much with tooth wear. But if you actually have it in between meals, then it's much more risk. So in other words, if you're advising your patients when they're having their acid intake and they're having it with their main meals, then it seems to produce less tooth wear. But if they're starting to have acidic intakes in between meals, that actually increases the risk of tooth wear. And generally speaking, 3 or more acid intakes daily, it means there's increased risk of tooth wear. Okay. Interestingly, one of the things that we always do for tooth wear patients is ask them to use a softer toothbrush. And the research that we did actually found that it actually makes matters worse. So if you actually get a patient and they start using a soft toothbrush, then there is actually increased tooth wear rather than decrease. And we feel that this is because that the softer bristles trap the abrasive toothpaste more, and they have a much more tooth wear effect. So the advice really is not to go towards a soft toothbrush, is to go still to stick towards something like a medium one. And then you have certain habits that make matters worse. Swishing drinks, gargling inside the mouth, that increases tooth wear. So you have an acidic drink, and if you swish it inside your mouth, it makes matters worse. If you were to have it with a straw, it's better. And remember that whenever you're looking at behavioral changes, which is probably very relevant in this current climate that we're living in, is that it needs reinforcement. The message needs to be reinforced, and you always need to look at substitutes rather than elimination. It's patients don't respond very well to saying, don't have that, don't have that, don't have that, don't have that, and that's it. You need to actually recommend substitutes in order to create a change in behavior. Okay, and so it's not just like, with anything with these behavioral sciences, is that you have to reinforce it, and you always have to produce a substitute rather than being a completely no affair. Generally speaking, low dose fluoride, things like Durafat, which we get in the UK, 2,800 parts per million, continually used, is better than the high dose, which is a 5 part per million. And that's for the UK. I would like you to now just transpose this to your current practicing environment, where perhaps there's already fluoride in the water at a high level, where you may want to actually look at this advice with a slightly different light. And we're coming back again to critically appraising literature and research, okay? But generally speaking, we have 1 part per million water fluoride in the water here in the UK. And if that's the case, then we recommend that you have a low dose fluoride intake with a Durafat paste, which is 2,800 rather than a high dose. And the use of occlusal splints, okay? And generally speaking, the occlusal splints that we make, I'll show you an example of one in just a moment, are full coverage splints the patient wears in order to protect their teeth. Just remember with occlusal splints, a very important factor here is that for patients who have intrinsic chemical etiology of tooth wear, in other words, GORD or gastroesophageal reflux, you need to be very careful about using occlusal splints, because when they use occlusal splints, then the acid from the intrinsic acid gets trapped within the splint and actually causes more problems. So just be a bit aware of asking patients to use occlusal splints for people who have, intrinsic erosive factors here. And here you see an example of an occlusal splint. The one on your screen on the left is an upper Michigan type splint. I always recommend a hard occlusal splint. And on the right hand side, you see a Tanner type appliance, which is for a lower. And what you're really looking out for is even centric stops. You're looking at so that the splint actually touches all the teeth evenly. Okay, the surface is very flat, and that when the patient grinds from the left to right and forward, in other words, in any lateral excursion, there is the disclusion of the posterior teeth. So this is the occlusal prescription that we would actually go for occlusal splints. So it's even centric contacts and then disclusion as the patient goes left and right, so on. Okay. And that's what you're looking at there. So here on the left-hand side, you see the upper one, and on the right, you see the lower one, but the prescription is exactly the same, okay? It's a hard occlusal splint that you would prescribe, not a soft one. Now, the particular area that we're going to look at today is localized tooth wear. So far we've looked at the etiology, we've looked at the diagnostic aspects of it, and we looked at prevention. And now I'd like to look at the restorative management, and in particular, looking at localized tooth wear. And these are the kind of examples we're looking at, where you kind of have a localized tooth wear, for example, here in the front. You can see this canine is quite badly worn here. Similarly here, here, and here. These are sort of individually localized tooth wear. The rest of the teeth are okay. All right, and these provide us with a sort of a challenge restoratively as to how to deal with it. And what I want to also want you to do is, if you had this patient in your chair on Monday morning, is how you would classify this. So you can immediately see that this is an example of severe tooth wear in these cases here, okay, and less pathological perhaps, okay. It's very severe where a lot of the crown has gone, okay, and you are faced with severe tooth wear. And that's what we usually see in these localized tooth wear. And so how do we go about managing this and the strategy for managing this restoratively? In order to appreciate how we're going to manage this, we need to look at a phenomenon known as relative axial tooth movement. Okay, this is a phenomena that I want to acquaint yourself with, and some of you might already be acquainted with it. It's a very, very effective role in the management of these kind of cases. And this kind of relative axial tooth movement was first described in the 1970s by a clinician called Professor Dahl, who was in Oslo. And here you see the two papers on which these things are read. But he actually proposed this in 1975. Okay, so and now the relevance of it is becoming clearer. And so the original idea actually comes from this background. So what is relative axial tooth movement? Essentially, it refers to a movement that occurs with the teeth, whereby you actually put an appliance or you make an area of supra-occlusion of the supra-occlusion, and you allow the rest of the teeth to contact. Okay, so I'm just going to ask for, excuse me, just for a minute, please. I just had to knock on the door. Garima, I'm sure you can hear me. I just need to attend to that. I'll be back in 2 minutes, please. Yeah.
Oh, no worries.
Sorry about that. Yeah.
Okay, guys, so sorry about that little interruption. Just hold on for 2 seconds, and I'm sure he'll be back. Guys, again, many of you are asking me if you'll get a certificate for this session. So, sorry, I just realized my video is off. There is no certificate for this particular session. This webinar was mainly just so that you could learn a little bit about, wear from Dr. Banerji, and then also later on we're going to talk about the postgraduate diploma and a scholarship that IDEC Academy has available to it. So we'll have a chat about that just in a bit once Dr. Banerji finishes this off. If you guys have any questions on what you've learned till now or heard till now, please do put it in our chat box. And thank you everybody for keeping their video and audio turned off. Just makes things a lot easier for us. We might just, since we're waiting for Dr. Banerji, we might just start talking a little bit about the postgraduate diploma. So he'll talk about it in detail, but it's a 2-year postgraduate diploma that's got a UK recognition to it. And it's a blended learning format where you do online components as well as hands-on components. And the hands-on component will be in Mumbai at the IDEC training center. We'll show you some pictures of it in a little bit. Oh, we have him back. So I'm going to hand you back to Dr. Banerji, and I'm going to disappear again.
Thank you so much, colleagues and Garima. And I do apologize. I just said we have a lot of home deliveries, and there was persistent knocking on the door, so I had to attend to it. I do apologize for that. So coming back to where we left off, we're talking about relative axis tooth movement and where it comes from. But essentially what we're looking at is this movement whereby we put a area of supra occlusion in a way of an appliance perhaps, and then allow the rest of the teeth to actually occlude together again. Now, interestingly, although it was described at Dahl's work in 1975, orthodontists have been doing this for years. Okay, so orthodontics in adolescents and even sometimes in adult patients, I suppose, they have been doing this for overbite reductions and so on. So it's not particularly a new concept as such, but from a restorative point of view, from restorative dentistry, it was actually described by Dahl. And I'll show you what I mean with clinical cases. And what research has shown that this objective of where you actually put a device or in somewhere in supra-occlusion actually works in the majority of cases. Okay, in 94 to 100% of the cases, this kind of system works. So what is it? So let's actually look at now some clinical cases, okay, some case studies to see how this is kind of applied. And the first case I'm going to show you is actually from quite a while back. I did this case in the 80s, and where we actually have this localized tooth wear. And this is where this phenomena is particularly useful, because here we have a case where there is some tooth wear palatally from the upper 3 to 3, okay? And what the concept really was or is that you place a localized appliance. Now, this is known as a Dahl appliance, if you like, and this is applied to the palatals of the upper teeth. Okay, you can see it here, and it kind of has got a little bite platform just in the anterior region here, but there's no, and there's separation of the posterior teeth. So there's no contact in the back of the mouth of the molars and premolars. It's just in the area between the canine to canine that this appliance is placed. And when you place this appliance and the patient actually wears it for a period of time, and this is essentially how Dahl did his work. This is my patient that I'm showing you, is that when the patient actually wears this for a period of time, what you actually have is a reestablishment of contact posteriorly and a space anteriorly, okay? Now, so at roughly about 3 months' time in this particular case, we've established some space, some, if you like, restorative space, which is palatal to the uppers. Now, how is this taking place? It's a combination of things. It's a combination of intrusion of the lower teeth, okay? And of course, movement of the posterior teeth. And there is also condylar repositioning. And this is kind of, if you like, the Dahl effect, if you like, that is referred to. Now, as it happens, we actually prefer it to be termed as relative axial tooth movement or these concepts in the adaptation rather than the Dahl concept. But this is what I'm showing you here on this, my patient here, is the actual Dahl concept. So then what happens is that the space you've created, you can actually fill it with a restorative material without actually cutting the tooth at all. So you kind of, I've in this particular instance placed a gold alloy. This is done in the 80s. This is early 80s as well. So there weren't much composites available. We were still looking at composites, but here I've done it in gold, and these are applied at the back, okay, in these veneers. And what you see here is that these veneers at 21 years. And so what you're actually seeing is that we've created the space, and without cutting the teeth, we have actually glued on some veneers at the palatal surfaces of these teeth. Now, what I want you to imagine here is this, is that these veneers are in a very sensitive and the forces are quite high on these veneers, but not one of them has come off in 21 years. In other words, these veneers are glued onto enamel, so enamel bonding works. That's the first thing. The teeth are not cut, and the fact that the patient is adapted to this bite, and more importantly, and most importantly, I think, is that the veneers, or these gold veneers, are in a space of a functional adaptation. Because if they were not, it's a bit like when you have crowns that are too high, is that they actually fall off. Okay, so essentially, they're in an area of adaptation, and where they've kind of adapted to for the patient to be able to function on these. So what you're seeing here is a 21-year recall. So what we do now is actually apply that concept when we look at localized anterior tooth wear. Is if, for example, you have tooth wear like this, and in the anterior region, you don't restore all of the teeth. You just basically now place the composite, in this particular case, directly onto the teeth, and you initially have the posterior teeth separating, and then after a period of time they come together. In other words, we eliminate the dull appliance now. We go straight for the restorative. It's important to point out that this is a material that can be adjusted, and so therefore composite, and we utilize this principle for actually dealing with localized tooth wear like this. Similarly here, what you see is that the same case, and this is at 8 years. So in other words, in 8 years, the composites are still there. Okay, so this is a very effective way of dealing with localized tooth wear that we see. So when we have cases like this, where they are localized, and in other words, to emphasize that the other teeth are not worn down, it's just in a particular area, we just go straight and do an additive solution to this, and just add, and then basically allow this dial effect, this relative axial tooth movement, to re-establish the occlusion at the back. Okay, so this is kind of how the principle works very well in localized tooth wear. Now, of course, the situation can be reversed. You remember you saw this case earlier on, where I showed you the severe tooth wear here. And if it can work on the upper teeth, it can also work on the lower teeth as well. And so what what I've done here is basically added to the teeth, okay? And then gradually, after 3 months, the posterior teeth have kind of re-established contact. So we've done exactly the same as we did before, but now on lower teeth. Okay, so it's localized tooth wear on lower teeth, and particularly if you notice the canine, you will see that by adding it, we have distinct advantages of not having to do endodontic treatment on that tooth, and this put on. And again, these treatments actually last for a while. So this, what you're seeing, is a 4-year post-operative view of the same case. Now, what I want you to notice actually here is have a look at the top right of your screen and see how I initially built up the canine. You'll see that the canine had a better contour when I first built it up, but over the 4 years, you can see that the canine here has worn down. Okay, now this is an important feature to point out, to say that tooth wear is a dynamic process, and you need to be able to account for this if you're looking at long-term restorations. In other words, this prescription that I've given here has been adapted over 4 years to this by the patient's bite. Okay, and because this material allowed this adaptation, it was possible. And the question I'd like you to sort of pose to you for thought is that what would happen if this was a material that did not wear down at all? Okay, so in 4 years' time, 5 years' time, 20 years' time, what would happen if that material did not wear at all? And in other words, there was no accounting for physiological wear. Just the thought, hold that thought in your minds. So if we can kind of adapt this to the front of the mouth, could we do something in the back of the mouth which is similar? And to answer that question, we've kind of looked at some research I did with cracked teeth. And these are some of the published literature that I published in for cracked teeth. Where essentially we are placing an individual molar tooth in supra-occlusion using composite. Okay, and this was a sort of a concept that I developed myself a while back, and what we found was that the kind of concept of relative axial tooth movement worked for this as well, and we were able to apply this for localized tooth wear in the molar area too. So you'll remember this case here where we've got two worn down molars here. Okay, all the rest of the teeth are intact. Okay, so what I'm going to do here is just add to these teeth. The patient here is complaining about sensitivity. Okay, as soon as I've added onto these teeth and just localized that in the area, of course you'll appreciate that the bite is separated. The rest of the teeth are separated. But what's quite interesting is what happens over a period of time. And here's the case, same case in 11 years' time, where the composites are still there at the back, and the teeth have reestablished contact. Okay, so we're using this relative axial tooth movement for our purposes to actually control localized posterior tooth wear. So it's not exactly the Dahl principle or the Dahl concept, because Dahl actually was referring to anterior tooth wear. Here we're looking at applying that principle posteriorly, and this, of course, provides quite distinct advantages for us for treating this kind of a problem. So when you have a case like this, where you have individual teeth that have got severe tooth wear, okay, you would just essentially add to these teeth, okay, and then the rest of the teeth would reestablish. Now, you may also appreciate that if you did not want to leave it in composite, once the patient did adapt to the bite, you could, of course, change that composite for something else, because you've kind of created the room. So your management of a worn down tooth is done really without cutting that tooth at all, which is a very distinct advantage for the teeth like this, as opposed to putting them into a more risk area with endodontics, etc., and post-crowns perhaps, okay? So it allows a very conservative way of dealing with these sort of scenarios where we have tooth wear, and you just build them up. Okay, here I build them up with composite, and then the occlusion reestablishes. So we're kind of using this concept for it. You have to be aware, of course, that when you're using this concept, as to make it most effective, there are certain parameters that I would recommend that you follow. The first one is I think, and that's the reason why I said that tooth wear goes very well with occlusion, is that you really have to understand how to apply the principles of occlusion. Okay, and it's important to be able to do that. The teeth should not be periodontally involved. Okay, so in other words, in all of these teeth, we have got good bone support. And of course, if you're familiar with primary and secondary occlusal trauma, you'll know why I'm saying this. The teeth should not be mobile, and this also relates to primary and secondary occlusal trauma. My recommendation is that you have to avoid lateral loading on posterior teeth. Okay. However, this concept here is interesting because quite recently there is some research coming through which is saying that this may not be a problem. But however, in my view, I still maintain that you need to avoid lateral loading on posterior teeth if you are doing this principle. You have to monitor the occlusion. You have to be very aware of how to monitor it, of course, and you monitor it throughout the lifetime of the restoration. And of course, the patient has to be compliant and has to be aware of what's going on. There's no presence of TMD. I would recommend not to do these on patients who are presenting with temporomandibular dysfunction. It's generally applicable when some wear of the teeth has taken place. In other words, you're not just adding to teeth that are not worn, you're seeing a tooth, and if you think back to the clinical pictures that I just showed you of the molar and the incisor teeth in front, they were not like that when they first erupted. So you're kind of getting them back to their physiological norm, if you like. So some wear has to have been taking place. My recommendation is to always, initially at least, use a reversible or adjustable technique. In other words, we no longer use that dial appliance anymore, but I do recommend you use a reversible material. In this particular case, direct composite works very well. And then once the patient's occlusion is equilibrated and the movement has taken place, you have that choice of replacing that material, because now you do have the space and you've actually created the prescription for your patient. And the other recommendation I would have is not to do it straight after orthodontic treatment, because here, again, coming back to occlusal principles, you will appreciate that you have actually torqued the teeth during orthodontics, and then to actually apply more load may not work out in the best advantage, okay? So essentially, when we're looking at severe tooth management, you have to establish the etiology, of course, so that you can establish a diagnosis. It's you need the effective prevention measures, and then the treatment should be as minimal as possible, as conservative as possible, and you also have to be aware of what's known as the dynamic restorative concept, which is essentially when you're restoring a tooth, you have to account for failure and wear and tear in the future, and how you would actually manage that problem. Okay, and of course, managing patients' expectations, how you'd inform them of what you're actually doing, because it's quite uncomfortable having a single tooth high in the mouth for a period of time and allowing that equilibration of the occlusion to take place. So your patient management here is very important, of how you manage your patient's expectations and why you're doing this. And of course, coming with that is the confidence of doing it, of course. And the recommendation, of course, is that you kind of be as additive as possible. So indirect, minimally invasive techniques are what are recommended. And use of crowns, I would say that we actually sometimes might have to use crowns, but be very aware of, generally speaking, what happens with crowns long term and the effect of the longevity of the tooth. And for example, if you see here, this is a student of mine who I taught several years back. He was from Spain, from Asturias in Spain. And he was one of my students. And we did this case where he has actually used an indirect method to deal with what I would call a combination of severe and pathological tooth wear. And he's done it with indirect restorations, with implants and indirect restoration. So he's built up the teeth. We're using crowns and individual crowns on implants and also on the teeth. So this has been a subtractive, and it is not minimally invasive. The only thing I would say here, and what you have to be aware of, is some work done by Professor Burke. He's from Birmingham, a very good friend of mine, Trevor. And what he looked at was did some lovely research, actually. He basically looking at the survival of restorations over a long period of time, which actually is very, very difficult to do. Actually, if you do this in from a research perspective, it's very difficult to actually monitor things long term and get viable results. But what's interesting about Trevor's work is that he looks at a huge number. So he's looking at 3 million patients and 1.2 million crowns. Trying to see these sort of marks on my, that's disappeared, and 1.2 million crowns. So he's basically looking at a huge database, okay? And what I want to share with you is his findings when he compared crowns and large composites, okay, like the ones you've kind of seen. And what's quite interesting from this data, I feel, which is quite relevant for this topic, as well as restorative dentistry, is that although crowns, around about the 15-year limit, didn't need a lot of intervention, okay? So basically, when you put a crown on a tooth for about 10, 15 years, you don't have to do much to it. It's kind of well maintained. Whereas if you put a large composite, you may have a chipping or you may have to polish it. You need to sort of do things to it to sort of maintain the restoration. But what was very, very interesting in this research, that if you crowned a tooth, majority were extracted and lost. In other words, the failure following crowning a tooth is catastrophic. Whereas failure after large composites is that it's not catastrophic for the tooth. The tooth usually survives. 83% of the teeth survived. So in other words, what you're looking at here is a survival of the tooth rather than your restoration. Now, this is very important, of course, when you're talking to your patients as to how you would manage an issue. Is that if you crown a tooth, particularly a young patient, you're looking at losing the tooth, the more likelihood of losing that tooth and what to do next, as opposed to if you built it up with a minimally invasive restoration, okay? And that's always worth looking at. If indeed you do decide to use a minimally invasive indirect restoration, one technique that you can do, and I'll show you a brief example of here, is that if you are going to use a ceramic restoration, is a lot of the time your ceramic restoration is quite extensive and you have to cut the tooth quite extensively, mainly because of the path of insertion. And you can actually deal with that by actually having a tooth which is worn here, and rather than making it in one unit, to make your ceramic restoration in 2 units so that they have 2 different paths of insertion, okay? And this is where adhesive dentistry comes in its own, is that you're actually making this crown, if you like, or the crown concept, but you're kind of making an onlay and a veneer. So you're making it 2 different directions so that the path of insertion is, there's 2 paths of insertion. So you don't have to cut a lot of this precious enamel away in order to provide an indirect restoration, okay? And when you put this in together, that's what it looks like, all right? So you kind of encompass the tooth that you're trying to protect in ceramic, but they're done in 2 different parts with 2 different parts of insertion in order to protect the tooth. And because you don't cut the tooth for a conventional crown, you preserve all the enamel and therefore the bonding surface, and hence the longevity of the tooth itself, okay? And that's quite an interesting concept which I do in my practice now when I am crowning teeth, all right? Rather than the conventional crown work. Last few slides are on the monitoring and the maintenance. You always have to monitor your patients after you're doing some treatment. You can use study casts, but of course, these casts you have to keep in order to show you a sort of a pattern of wear that is happening. This is quite sort of visual for the patient as well to see that there's a progress happening, and if something was not done, perhaps the difficulty comes when managing it. You can use clinical photographs, you can use indices, and of course, you can use software imaging. Clinical photographs have to be standardized so that you can actually see the surfaces and monitor them long term. But I think software imaging is something that we're going towards more and more now, where we can actually capture the surface and you're able to see what sort of wear is taking place over a period of time. And here you see an example here that over a period of time, and if you just pick up this area here, 1 year, 1.5 years, you can actually see that this is a progressive lesion here, okay? Similarly here, okay? So the doctor software is involved in some research with 3D at the moment. And there's a lot of software that's available to actually keep a monitor and check. And these are very good aids for patient information too. So the patients are very aware of the problems that can occur, and they can have a visual sort of representation of what's occurring and become part of the patient education process where you're alerting them of the diagnosis and problems, and they can actually come and see you. For example, you want to intervene when it's easier than later, okay? And making that point, you can use this software imaging for that. So I've kind of focused on a very particular problem. I focused on localized tooth wear. There's something that we see. Of course, there's different. I haven't really touched on generalized, but I just thought I'd use this sort of short presentation to just show you how we are dealing with localized tooth wear now, which is quite applicable. But I also wanted to draw in the different kind of disciplines that are involved when we manage tooth wear. Okay, so that was my presentation, and thank you very much for your patience. I apologize again for the brief interruption. I'm very happy to take questions on this, or indeed the program as well. And thank you very much for your attention. I do hope you found the presentation useful.
Great. Thank you, Dr. Banerji. It was informative as usual. We have had quite a few webinars done by Dr. Banerji, and I think each one gets better. I learn something new every time I listen to you. We do have questions. So should we start with the questions regarding the webinar first and then have a quick discussion on the diploma?
Yes, I'm very happy to do that. Yes, absolutely.
All right. Dr. Basu wants to know, can we use some other veneer other than gold alloy?
Yes, Dr. Basu, very good question. The gold alloy that I showed you in my example was done on a patient years back. It was in the early 80s. In those areas, we were very unsure of course, of this approach. I know we had looked at the research, but we were unsure of the approach. And so I used gold then because it's a material that's it bonds very well, particularly with Panavia, and of course it's got that malleable property over long term where the bite can adjust over a period of time, and hence you saw it for lasting 21 years. Nowadays, I have to say I don't use gold for these cases. I would go straight to something like direct composite usually. Goran Benik, who I showed you in my expert panel, he works in Switzerland. He's looking at ceramics. Just remember with ceramics is that they don't sort of yield very well long term in the way that they behave. So, but I think using composite initially and then switching it to something like ceramic is perfectly okay. But yes, in my practice, I find that direct composite works actually the best. I hardly use gold alloys now.
Great. And Dr. Srivastava wants to know, what is the impact on the TMJ by this method? I'm assuming the dull method. Yep.
Yes, that's right. A very good question, Dr. Srivastava. Very relevant question, because for a long length of time, we were particularly worried about this aspect. It's what actually happens if you make individual changes in this, and how does it affect the TMJ? You remember from the slide I showed you about the do's and don'ts, if the patient has TMD or any TMD issues, I wouldn't recommend this approach. That's the first thing to say. The second thing, which is very interesting, in both of the research that I have personally done, as well as looking at the past orthodontic research and past research done, research done by other colleagues on the subject, we all arrived at the conclusion that it did not precipitate any TMD problems. It precipitated a lot of patient complaints of adapting to this strange occlusion for a period of time, but no issues with the TMD. So that's what my own research has shown when we looked at cracked tooth, and when the research done in the orthodontic literature, as well as other restorative literature. So the answer to your question is, interestingly, it doesn't precipitate any TMD issues.
Okay. What's the best filling material for cervical lesions?
For cervical lesions, I would recommend nanohybrid composites. Nanohybrid composites, very used with a good, three-step bonding regime, moisture control, and a nanohybrid.
Great. Just 1 second. Okay, 2 questions from Dr. Nick. When you add the resin to the tooth that has undergone severe wear, how much addition would be required, and how do we decide that amount?
Very good question, Dr. Nick. The answer to the question is actually, there is no exact science to it. What actually happens is that you try and restore the tooth to its anticipated pre-worn form. So it is a sort of a, if you like, a estimation you make. And I'll take you back to the my decision process is always direct composite because of this uncertainty. Your composite, the material that you're adding has to be of adequate thickness for its own strength, and then it has to be adapted by the patient in use. And the adaptation factor is something that is very difficult to determine numerically beforehand. It is something that you kind of find out. And this is why our recommendation and my protocol has always been to find that position of how much to add with a material that I can adjust and add and subtract to. Because then what happens is that as adaptation takes place, you're able to then ascertain the prescription, so to speak. So Dr. Nick, so essentially there's no way of knowing how much. All we know is that we need a particular amount, and composite is usually a millimeter of thickness that you need with composite for it to work for a given time. So we know the space we need, how much to add, we kind of titrate accordingly. And it really is a process of finding out. But generally speaking, if you were to restore to the contour that you feel anatomically was the pre-worn contour, then you fall within the adaptive area of your patients.
And his second question is, could you please repeat what is the advantage of the two-part crown technique?
Basically, with a two-part crown technique, is to do with your path of insertion. If you think back to your prosthodontics and your crown preparations, you usually have a incisal path of insertion. Okay, now I would like you to imagine a tooth like a canine, for example, which is a very bulbous tooth. Okay, and it's very bulbous in the sort of the gingival portion. If you think of crowning that tooth, you'll appreciate how much tooth you have to reduce in order to have the crown fitting from the incisal perspective. So in other words, it's a path of insertion that dictates the amount of tooth that you have to remove. Now, if you could just break that down and have different paths of insertions, one perhaps from the labial aspect and the other from a palato incisal aspect, then of course your prep is very different and becomes much more conservative. And if you translate, if you like, that image of your canine onto a worn tooth, where a tooth is worn down, the same applies, is that if you could make that crown in two parts with different parts of insertion, then you don't need to actually remove that amount of tooth in order to produce the result, okay? So it's basically encasing your tooth with ceramic by hardly cutting it, because the tooth is already worn down. The same sort of thing applies when you're dealing with endodontically treated teeth, where you've got a large access hole, or you've got an access hole in an endodontically treated tooth. And on top of that, if you then start trimming down the periphery of the tooth in order to place a crown from the incisal, the tooth becomes very weak. So with this concept, what actually is happening is that your crown is made in two parts, sometimes three, and you're kind of enclosing that tooth completely with ceramic, without really cutting it. So it's to do with path of insertion. And incidentally, if I may, Garima, I'm just going to expand a little bit, because this is exactly why, in coming to a little bit of the courses I design, is that in order to understand the whole management, it needs to be a sort of a step-by-step approach, as well as looking at different aspects. There have been questions about materials, there's question about TMD, there's question about tooth preparation. And in order to understand concepts like this, the whole thing has to be quite wholesome. So your questions are bringing out very important points. And in order for me to address them fully, or be able to train you perhaps fully to tackle these, I need to make a very broad, structured approach to my presentation in order so that you have all aspects of this. So to answer your question, yes, it takes you back to tooth preparations, to the fundamentals of tooth preparations, how we can adapt that to use this.
Dr. Neeraj Kumar, no, sorry, I've got that as the wrong one. Dr. Roma, if the tooth wear is extensive and deep bite, do you still do direct composites?
Yes, I do. So Dr. Roma, I always use a direct composite, mainly because I need to see what extent I can actually increase the bite by, or increase the vertical by. As I was saying earlier on, there's no research, there's no actual documentation of how much you're able to use. and you have to titrate that according to your needs. And so I always use direct composite. Once I establish that prescription, if you like, then I might change that composite for another material in time. But I always use direct composite. In my hands, that works the best, and in my research colleagues as well.
Is laser treatment good to relieve sensitivity in the case of attrition?
Mixed research on that. The answer, in fact, it's interesting that you bring that up. Well, my current MSc student is actually looking at that very topic and looking at the literature. The answer to your question at the moment, and this is pre-publishing, if you like, there's a paper going to come out very in a few, I think next year actually, about this. The evidence is very mixed at the moment. In some cases, yes. In some cases, no. It is not something. And I presume you mean hard lasers. In fact, even if you mean soft lasers, both of them, it's not a given that it will always solve your sensitivity issues. But there is some evidence about it. But I don't think it's categorically the only way of dealing with sensitivity.
Okay, Dr. Kiran would like to know what amount can be considered normal attritional wear on incisors, and when should the attritional wear be treated, or is this age dependent?
Essentially, if you're looking at tooth wear, if you're looking at pathological tooth wear, that is the rate, and that is age dependent. Severe tooth wear may not be age dependent. It may be as a result of maybe previous trauma and then subsequent wear, so that won't be age dependent. So if it's severe tooth wear, it's the amount, and that's not always age dependent. Pathological tooth wear is age dependent. When do you intervene? Essentially, what you're looking at is you're looking at the patient's symptoms, signs and symptoms, or if you yourself feel that by ignoring this any further is going to make a full arch reconstruction more complex later on, rather than adding a little bit of composite or perhaps one or two areas where the tooth is worn and so on. So you kind of, or maybe even preventing it with an occlusal splint if you feel that bruxism is playing a part as well. So that would be determined on that. The rate, the interesting point you raised there, Dr. Kiran, about the rate is something that I think is still debatable. I know we came up with some figures at the very beginning of this the presentation. I showed you a slide where we actually put down some figures of what we considered as physiological tooth wear. But I have to say that it would really depend on population to population, and I'm sure it will also depend on which area of the world we're in, and of course, which region we practice in. So I would have to say that the jury is still out on what we would class as physiological tooth wear. And I dare say my personal feeling is that it's very population dependent. What would be considered physiological in India might not be the case in Europe. I've done some work in India in a charity hospital in Chitrakoot, and where I found there about wear patients is that some of the complaints are not there. There is no aesthetic complaint. There is no functional complaint. There is no sensitivity complaint. So then is it pathological? And the question is open. Whereas I'm kind of seeing that the same patient in the UK or in Europe would complain about aesthetics, and then it suddenly becomes pathological because it's aesthetic. So it's a very open question. It's a very good one. But I think generally speaking, the flow diagram is meant to guide you towards it. As to what you would do, but patient awareness is very important. And I think software imaging would make a difference, where you can actually see that progressively a tooth is wearing down, and that the patient needs to become aware of it.
Dr. Nadeem, what is the long-term success of providing crown in two pieces as compared to one piece?
This concept is reasonably recent. It's not has the same background as conventional crown work. The preliminary results are very good. Mainly the way they're failing is leaving the tooth behind. I think that's one important aspect to look at, is that when they fail leaving most of the tooth behind. So they don't fail so catastrophically. And in where patients, some work was done by an Italian professor, Professor Vagliati. And if you look, Francesca Vagliati, and she's had to look at this. And it's a concept that we're reasonably confident about. Because the reason why it works primarily, I think, is not so much about the material, it's the bonding. The thing to always remember that when you're using any indirect material on a tooth, in order to get the maximum effect, it always depends on the bonding rather than the material itself. So in other words, you don't solve the problem by using a stronger material. You solve the problem by increasing the bonding potential, and that's critical. So the more you leave the enamel behind, the better off you are for your case, because you're bonding to enamel. As soon as you take that enamel down and you're down into dentine, the flexure of the tooth changes as well as the bonding capacity. And that's where it's the issue. So we feel confident with this approach because it's ceramic bonded to enamel. So I think we feel quite confident to it. And the failure at the moment is mostly on the bonding. It's actually a very difficult restoration to prep and very difficult restoration to make for your technician. And that's where the challenges are actually. And of course, you sure as hell can't do it on your CAD-CAM. It has to be done laboratory based. So you have to be very confident of your technician being able to provide you with these two separate things.
Okay. And two more questions, and then we'll start talking about the diploma, I think. Dr. Srinadu, which are good restorative techniques for cervical abrasions?
Restorative cervical abrasions, of course, just make sure the etiology, make sure of the fact whether it's sort of because of toothbrush abrasion or because of habits and things, or if it's due to a kind of an abfraction concept. If it's a fraction concept, what you might have to do is look at the lateral loading on the tooth. So make sure that you are reasonably happy of the lateral loading on the tooth. And once you do that and you kind of are confident of the lateral loading, then you essentially, sorry, I'll just stop sharing my screen actually. So then what happens is that when you take the lateral loading away, then I would say direct composite works the best. So essentially you have a scenario of if it's purely due to toothbrush abrasion, for example, then of course that habit has to be modified first before you add the composite. But if it's abfraction type lesions, if you believe in that, incidentally, there's a lot of controversy about that at the moment. But if it's occlusal forces that's causing it, then you have to address that as well as what you would add.
Great. And Dr. Gio, in case of gross attritions, vertical dimensions may change in that case. Restoration of vertical dimension necessary when correcting with direct composite.
Yes, it is. And I think this is actually referring to a case generalized tooth wear where you kind of got all the teeth that are worn down. And I know this particular presentation was not focused on that one, but if you're doing a sort of a generalized tooth wear where all the teeth are worn down, it's a full arch reconstruction where you have to increase the vertical. And I tend to do it in a reversible composite material or in a reversible material, establish the occlusal prescription, and then swap it for more hard-wearing indirect materials if necessary.
Okay. And last question from Dr. Kiran. Does periodic fluoride application, will it help in protecting from tooth wear?
Yes, the research does show that. It's the lower fluoride concentrations work the best, the 2,800 parts per million Durafat pastes. I don't know if that's available in Mumbai or not, but essentially you're looking at a low fluoride concentration but regular application. That works better than the high concentration. I don't know the reason why, actually, to be quite honest with you, but we just found that actually the lower concentrations work better than the higher concentrations. And the only thing to watch out for there is how much natural fluoride there is in the water initially, because of the fact you don't want to overdo the with the fluoride.
Yeah. Just 1 second. Okay. Dr. Srinathu, what will be better treatment plan for generalized attrition with habitual bruxism?
Ah, that's a.
Yeah.
How long have you got? It's the reason why I actually just spoke to one problem in tooth wear. And I'll answer your question briefly, if I may, because it's quite a complex question that you have asked. When it's generalized tooth wear, it actually goes down to the principles of full arch rehabilitations and how you would determine occlusal prescriptions for that. But basically, what you're looking at is you will probably have to deal with all the teeth. You will then have to titrate your occlusal prescription in a reversible way, and then flip it for the materials that you do want to use long term. And it may be a combination of composite and ceramics, or all ceramics. It'll depend very much on that. And then finally, if you're suspecting your patient is a bruxist, is to actually consider occlusal splint wear, whereby they actually wear an occlusal splint to protect the teeth further. Bruxism is a very interesting issue because it's very difficult to get patients to stop bruxing. And there is some evidence very recently coming out from some work we're doing, is that it may have a genetic predisposition for bruxism. And there might be a gene for it, but don't quote me on that. This is something that is very recent. So we're kind of coming to the conclusion that once a bruxist, always a bruxist. If you can get rid of those patients some way or the other, refer them to a colleague of yours who you don't like. That's always a good way of doing it. But if you are dealing with bruxisms, always be aware of failure, restoration fracture, how you'd manage the restoration fracture. And of course, if it's just composite fracture, it's easier to manage than if half the ceramic or the tooth breaks off, of course. And then, of course, using something like a full occlusal splint of the types that I've shown you, not soft, because soft splints actually makes bruxism worse. And you need to use a hard occlusal splint with the particular prescription for it, so that to protect the restorations afterwards.
Okay. Okay, questions just keep coming in. I think we're finishing. Guys, we've got 2 more questions and then we're going to close it for questions, because we do want to talk about the diploma. Dr. Rapsang, does CPP, ACP aid in prevention of tooth wear and sensitivity?
CPP is, remind me what CPP is.
Oh,
recalcitrant. Oh, yeah. Okay. Yeah, I think they do. There's some evidence from them. They do the tooth mousses and stuff like that. The other thing that you need to watch out for is keep them away from whitening toothpaste, of course, because they're quite abrasive. But yeah, there is some evidence with those recalcitrants and tooth mousse. I think GC made a product called tooth mousse. I think. Yeah, I think they work, but yes, I think there is some evidence there.
Yeah, I've personally had great experience with tooth mousse for sensitivity. Works charm. And last question from Dr. Nadeem: would you prefer direct composite restoration rather than indirect restorations for bruxism patients?
I personally probably would, and I've got 2 groups of patients. For some, somehow when you increase the vertical and they have severe tooth wear, somehow they adapt to it better, and the wear and tear is reasonable. My worry with changing to indirect is, of course, always the failure. One thing that I'm doing a fair amount of now is, once I've established the occlusal prescription, is just to take that composite off and just put this 2-part ceramics on, or just a ceramic onlay on without tooth preparation. And then the issue then is that it looks a little bit more aesthetic and so on. Yeah. So it's Benek is doing some work on some feldspatic ceramic that he's bonding to tooth. Now, what you've always got to remember is that you should have good quality enamel for bonding, okay? And if you have good quality enamel for bonding, if you can hold on to it, so, you know, just make sure you do. And any preparation that you do bonds onto it, it will be better. So I personally prefer to always start with composite, and then I've now started to replace that composite with these two-part crowns, or, you know, these funny looking, you know, preparations and stuff like that, that you can do with these other things. You can actually do two-part anteriorly too, you know, so you build the front tooth in composite, establish the aesthetics, establish the function, and then put a ceramic veneer from the front and the back and enclose the tooth without actually really cutting it. But you have to be very careful prepping it. It's a very sensitive prep. It's not that easy to prep, actually. So you make sure you charge your patients accordingly and get a good lab.
Okay. A lot of people are asking me if they can have a recorded version of the webinar because they found it really useful. I will put it up on the IDEC Facebook page and the IDEC website with links. And since we have all your email addresses, we will email it to you, the link to you. It's tough to send a huge recording to each one of you, but it'll be on our platform where you can access it at any point that you like to visit it and review it. Is that okay, Dr. Banerji?
I'm very happy with that. Yes, that's not a problem at all. Yeah.
One of the questions is that, is this postgraduate diploma course for international students or for Indian students? So I'll take the liberty to answer that one. It's for everyone. And I'm going to hand it over to Dr. Banerji. He's going to talk about the postgraduate diploma, and you'll learn a lot more about who it's for and how it's run. So, and Dr. Banerji, I might just share some pages while you're talking, if that's okay. Yeah?
Absolutely. Yes, please do. Yeah. Essentially, folks, what actually the diploma that I developed is actually a very personal project of mine that I developed. It's taken me about 7 years to develop, and it's as a result of I've kind of been sort of talking to clinicians around the world and what the need of general practitioners are, because I've been teaching at King's for a long, long time, and of course we have run MSc programs there. But I get this kind of feelings is that a lot of clinicians don't want this very intensive MSc program with the cost implications, of course, as well as the academic side is much more heavy-weighted with the research component. And it's something that they don't actually like to engage, but they do want the knowledge to actually be able to provide the dental treatment in their practices. And this kind of led me to this concept of how, with my experience and with colleagues that I have and teachers that I have around the world, to develop programs that kind of fits this niche really, who are people who perhaps don't want to go to the specialist registration examination process, but they just want to do very, very good general practice. And particularly in our profession, of course, as you're all aware, that we are entitled by a degree to do everything, perio, endo, ortho, implants, everything is possible. And majority of the treatment actually happens in general practice. So we developed this program, but one thing I felt was that it had to be structured. You know that one of the difficulties I find as an educator is that when I do short courses or a weekend course or just a short webinar, the amount of information that I can translate is very limited. So I prefer to have a structured go at it. So in other words, take people through modules, as you probably noticed from the questions, that there are lots of different aspects that come into being, particularly in postgraduate dentistry. And so I thought structure was important. And the other thing that is very important for me to engage with is, of course, I am part of the program and I've designed it, but to have who I would call world-leading clinical educators, people who have proven their salt, if you like, in doing it, researching it, as well as teaching it, because there's three different things here. If you just go to a researcher, the problem becomes is that, well, research is fine, but it doesn't translate into practice. How do I make money out of this? Then you go to a clinician who gives you anecdotal evidence of things that have worked in his hands or her hands, and they've attended a weekend lecture here and they started teaching you that. I don't feel that is a good environment. And we need what I would call clinical educators, people who understand the research, who have done it for a living, applied it in practice, and have also taught. And that's quite important. I've spent quite a lot of time in research in teaching, and it's quite a, I feel, a unique proposition to do. And the need I see is that, you know, there's too many short-term courses which kind of give you half the information. And what my experience is in the General Dental Council is that I see cases when they go wrong. So someone's complained about a practitioner. And when I look at those cases, I can see that the learning for this case has taken place in a piecemeal way. And the person has joined the jigsaw pieces in the wrong order, and the case has suffered. And for this reason is that what I've developed this course for. This particular one is on aesthetic and restorative dentistry, and I intend to take you through a blended learning approach, which is again suited for, and well researched incidentally, for teaching, for practitioners who have busy lifestyles. You know, you've got patients to see, you've got, you know, your practices to run, and you won't be able to and apply the time that you need for a full-time MSc course, for example. You want to study from home, you want the flexibilities of looking at things. So we designed this for you in a modular format where you intended to access the theory, if you like, in modular format, going through the foundation, the planning, the direct, indirect, and the papers. And so basically in the modules, you'll find videos, instructional videos, papers, chapters, etc., that basically go towards this. So that's an online component. And that online component is really covering all the theory that you need. And you're able to sort of go back, for example, and sort of look at a particular item again. We also have a lot of research-based articles in there for you to read. I've handpicked them for you so that you're able to read the necessary literature. And then we have a module 6, which is a hands-on component. And I have to stress that this hands-on component is not on patients for medical legal reasons. This is really speaking this aspect of the course that I can't deliver online, where you have to do the preps in front of me, where you have to do the veneer preps and the two-part veneer preps I'm talking to you about, or the composite bonding I'm talking to you about, or the face bow occlusions, the perio surgery that I'm talking to you about. All of those things, you need to do it hands-on in order to make that transition or the skill transfer to your practices, okay? And then there is an assessment element of it, and it has to be, because for a teaching aspect, we need to be able to see that the principles are learned and applied. And so the module 1 to 5 have internal online assessments. And then module 7, you have to present a couple of cases to me, as well as do some assignments. And that component then completes the diploma. The diploma is awarded by EduQual, which is basically an independent organization. It is not a university. And the reason for this is so that I have an external body looking at the quality assurance of the learning process, okay? Otherwise, rather than just be saying that, well, it's me and therefore it's okay, I have an external body looking at it and saying, yes, the assessment protocols has been done fairly, and it reflects the learning outcomes that the program is meant to deliver. Universities are notoriously difficult to work with. I work in one, and I said that, and Garima is about to embark on working with Melbourne as well. So good luck. But so that there is that component, but it carries with it a lot of rigor and which doesn't suit everybody, you know. And this is where this comes in, and that's why it's a diploma level program. It's level 7 recognized here. In the UK, we have private bodies that quality assure. And that's hence the thing. I would say to you in all honesty is that if you're going to do this program, do it for its learning concept, do it for what you're able to do for your patients in your surgery once you've learned it. The diploma piece of paper is just an added bonus. It's kind of, yes, it kind of proves that you've done it, and I think it's important to show your patients as well. But The main component of the course I'd like to think is this skill transference, where I'm able to, with my colleagues that I've handpicked, most of them have been either my students or colleagues that have taught with me. They have, for example, you saw a picture of Lois McKenzie there. Lois McKenzie actually runs the aesthetic program for Birmingham University. So we all have a pedigree of teaching, research, and clinics, behind us. And then getting you, transferring that to you, and making these clinicians accessible to you in order to teach. And it's all taught by my faculty. I don't use local faculty. These are sort of handpicked. Some are based in UK, some in Australia, some in US. I myself am obviously based in the UK. Karima is actually based, but she's trained from Australia. So we have sort of I've sort of handpicked my faculty who I know are satisfies these three components, so that we're able to deliver to it.
Okay.
Don't know if that.
Sorry, go ahead, Dr. Banerji.
No, I was just saying that, and sometimes the assessment aspect does worry practitioners, and I'm one of them. I don't like taking assessments myself, but it really is designed, and the reason for designing the assessment package that I have for this program is very different from what you've encountered from university. It is a learning assessment. It is not a punishing assessment. It is designed that you're able to show me that you understand the principles. And if you don't understand it, you don't fail. It just means that I have to explain it better to you. So that's an important thing to stress about the assessment package that I've developed on the program. Don't be worried about it, okay? It's something that is designed for your learning, not as a punishing scenario. And you don't get, have 2 goes and that's it. It's not designed like that. It's designed that it gives me feedback that a particular principle is not clear to you. So let me just engage with you, sometimes on a one-to-one basis, to explain that for you a little bit more than perhaps it wasn't after you finished the studying. You have to present 2 cases right at the end, for which what happens is after you've kind of done all the other modules, 1 to 6, I would like you to present 2 cases. Some of these cases you might already have or you're kind of working on. And then what happens is we've got this app on which you load your clinical material. And then one of us, usually myself or one of my faculty, will actually guide you through that case. So we have to develop it into a case presentation. And that happens on a one-to-one basis. And then you present those 2 cases to complete your diploma. And that's the sort of, incidentally, if you decided not to do the assessments and just do the learning content, that's fine by me. It's just, I won't be able to give you the diploma. This important thing to mention, I guess. I think you need to complete the assessments in order for me to award you with the diploma.
So guys, just a quick recap. It's a 2-year UK recognized postgraduate diploma in aesthetic and restorative dentistry. It's a blended learning format with 5 modules online and 1 module on site in Mumbai. And then the 7th module is the assessment part. Dr. Banerji, can you correct me if I've missed something? But this course has been run already and is currently also run in the UK, in Malaysia. And do you run it somewhere else?
I run it in Ireland as well. So essentially, we're running it internationally. The idea is that I've partnered with organizations like yourself and IDEC, which have the hands-on facilities. And I have to say, if you haven't been to Karima's hands-on facility, you must do. It's world-class. And so the center must have the hands-on facility for me to do the hands-on portion. Because the rest of it is online, and we currently have run it in Malaysia for the last 3 years, where we run it in the UK, Ireland, and we got interest in running it from Australia too. The thing to stress here is that the teachers are exactly the same, the teaching content is the same. So in other words, I fly out. I'll be flying out to India once your government or our government lets me in, and we'll be doing. I think the next one's scheduled for May. I think Karima. I think around saying the hands-on. Yeah. So I'll be personally coming there, and the faculty who come with me to teach will be coming there too. So we deliver the course. The standard is exactly the same wherever you do it. It's actually the design of it is very similar. Well, it is exactly the same as my master's program, where essentially it doesn't matter where you're coming from and where we deliver it. It's always the same standard. I don't want to compromise on that. So it's been running for a while in these places. We've got quite active groups. And the other thing which is quite interesting that I found very useful personally is making an international contact, because you will become part of alumni plus colleagues from all over the world. So we've got people on this program from Australia, US, UK, Ireland, Malaysia, Kenya, Hong Kong. They'll all come in. And you know what? When you're kind of able to discuss clinical cases with colleagues around the world, it's a very rich learning environment, because I wish I could say that there's always one way to treat a patient. There isn't. There's many ways. I constantly am learning from colleagues from around the world, talking to dentists I've met in India and around the world. The one thing I do know is that, there's always new things. And the more international that group is, the better I find the learning experience.
Yeah. So like Dr. Banerji said, it's been run in lots of countries already, and he currently still runs it in these countries. It's a 2-year diploma. It's going to start, Dr. Banerji, in October. We're going to start in October. So, and then the hands-on part in India for this batch will be in May, from 8th May to 17th May. So, and then you have 2 years to complete the online material. Something that Dr. Banerji also hasn't mentioned is that every month or every 6 weeks or so, you will have regular touch-base webinars with Dr. Banerji. Is that correct? Where
yes, that's with myself and my faculty. So essentially, it works out roughly one every 6 to 7 weeks. So it's given by myself, and also primarily because you might get tired of listening to my voice all the time, is that we do have other colleagues giving particular topics particular topics of interest. So, for example, we've just had Jim Dufty. He's a periodontal expert from Birmingham. He did one on perio. There'll be another George Cardoso from who I'm hoping that will join us in India, provide the Portuguese government and the Indian government allow an exchange air corridor. So he's coming to India, I'm hoping in May, but he will do, he's very good at doing perio aesthetics and veneers and gummy smiles. We have Kyle on implants and so on. So you will have different faculty also giving you their inputs, as well as myself on a webinar. What we do with these webinars is that we record them all. So if you were to go onto the site, what you'll see is what are known as recorded webinars and additional learning materials. In those areas, this is outside the modules that you'll see. In those two areas, what you will see, of course, is the webinar that we gave to your group, to be recorded and put there, but you'll also find webinars given to all sorts of groups, and you'll be able to sort of actually look at them all. And the other thing that happens is that in there, I've got a lot of articles and reading materials that I keep putting in there out of interest. So I've kind of looked at articles that are relevant, and then you're able to have that in one area there. The other thing I'd like to emphasize, if I may agree at this, and it's purely from my experience, about this postgraduate learning experience is actually very different from undergraduate learning experience. And I say that because I've taught both. The undergraduate curriculum is designed to make you a safe practitioner. In other words, you get to your standard, and it's very didactic. It's kind of, you do this way, or that's it, and that's the only way of doing it. And if you do it any other way, I'm sorry, you're staying here for another 5 years. Whereas postgraduate is very different. Postgraduate is about an exploration more than absolute answers. And I have to specify this because what actually happens in postgraduate dentistry, we are actually now colleagues. You know, I've done dentistry in a different environment in different ways. Everybody has done it in different ways. And the thing with it is that we all have ways of doing things. And the important thing is it's kind of exploration. And of course, there's new techniques coming out all the time. And I can't pretend to know them all, but to be able to equip you in order to be able to tackle the future of dentistry as well as the present is the aim, and in postgraduate dentistry. So there is a little bit of thinking involved, self-study involved, which is difficult sometimes to do when you have family commitments and so on. But the online content is really there so that you can actually refer to it at any time. You know, for example, let's take a prep. You saw me. We did we do a prep in Garima's fantastic center at IDEC, and you kind of see that, and you kind of, well, I saw what he said, but I wish I could see it again. So, well, you'd like to go online, and you see a video of me doing it again. So you kind of, and then you see clinical materials, then you see some papers regarding that coming in. So it kind of completes that package, so to speak, and that's where postgraduate is aimed towards. You know.
So basically, the online content, and I've got a list here given by you, Dr. Banerji, consists of recorded lectures, text, academic text, recorded videos, videos on techniques, videos on patients, recorded discussions between faculty and expert clinicians, recorded webinars, live webinars, multiple choice assessments, and short answer assessments. So you have a really, you know, an array of way to learn. And then of course there's the hands-on part. Just before, you know, we wrap up, I wanted to just share that, so for the course that's going to be run in India, which starts in October, IDEC has been very lucky. We had been applying and speaking to companies, and we've been very lucky to receive a few scholarship seats from Concept Pharmaceuticals, which is an Indian pharmaceutical company who've been wanting to do inter-education and support international standard education in India. So the scholarship is for 3,900 USD. It does not cover the full course price, but it does cover a substantial chunk. And they will pay that on your behalf if you are the scholarship recipient. And then the remainder of the scholarship price, the remainder of the course fees, IDEC is offering that you can pay it in installments. So if this course is of interest to you, guys, I would really urge you to apply for the scholarship. It's open for everyone, not just Indian resident dentists, but dentists from all over the world. And the scholarship applications are open till 31st of August. So you have 1 month. I think I have all your email addresses because that's how I sent you the link for today. If I don't have your email address, or if you just want to be sure, then please do email us at idecacademy@gmail.com. Or you can message us privately on our Facebook on IDEC. We will give you a link, an application form where you can apply for the scholarship. And then around the 1st of September onwards, within 10 days time, so 1st to 10th September, you will know if you have received the scholarship. Like I said, we start the course in October. So if you're interested, we would like you to get in touch as soon as you can. While I have you here, I've just got a few photos of the IDEC Academy where you'll be doing your hands-on that I just wanted to share with you. Dr. Banerji, let me know if you can see it because I'm not.
Yeah, sure.
Yeah. Can you see
yes,
that?
It's coming.
Yeah. So
it's
that's
coming up. Yes.
So
yeah.
that's
You
Dr.
can see it.
At the IDEC Center where we ran an occlusion course last year. So just a few photos on the academy. Sorry, there's a little bit of a lag. Let's try and get this one up.
Just wanted to say, Garima, actually, firstly, thank you very much from the for Concept Pharmaceuticals for offering the scholarship. That's very, very generous offer. And indeed, just for regards your center, is that one of the provisos that I had about taking this program around the world is to make sure that centers like what you see in your picture right now are available for teaching. I've taught around the world. I've taught in the US, I've taught in the UK, Australia, Middle East, and essentially, this particular center runs in the in the top notch here. So one of the prerequisites for me bringing the course to India, apart from the fact that I am from there and I would love to bring it there, is the fact that this sort of facilities is available. And having taught around the world, I have to say that this is work. In fact, if you don't mind me saying so, Melbourne University has just endorsed this as well.
Yeah.
So
you will be learning in a state-of-the-art center. So are there any questions on the postgraduate diploma part? Otherwise, I will message all of you the brochure and the link for the scholarship. But if you guys have any questions on the course or the scholarship, do let me know. You can always message me privately as well. I'm on Facebook, Instagram, and of course the IDEC email, which is idecacademy@gmail.com. So if there are no more questions, Dr. Banerji, should we wrap up today?
Yep. And thank you again for your interest, for the whole group, and I hope it was informative. And thank you, Garima, for organizing this, and to Concept Pharmaceuticals as well, because of the scholarship. It all ties in very nicely.
We're very grateful to them, because providing a $3,900 scholarship to each participant is a big deal, and I'm just very grateful we could get it. Yeah.
Well, I haven't managed that in any other center around the world, so congratulations. It's a very generous offer from the Concept Pharmaceuticals, and thank you for that support.
And guys, go ahead, sorry.
No, I was just going to say that we have, I think, 36 or so participants here. I'd love to welcome you all onto the course, but of course, the places are limited. So I'm hoping to see a lot of you in May face-to-face, but hopefully when you start the course in October.
Yeah. Guys, we do like to keep our courses small so that you get a lot out of it. So I think we're not looking at more than 17 to 20 participants for this batch, because that's how big the center is. Everything's done on simulation. So we have 20 simulation seats. So that's how big the course will be as well, because I do get asked that often, that we don't want to learn in a big batch. So you'll get personal attention from Dr. Banerji and the faculty. Guys, again, this webinar, I will send everyone a link for it, which will be off our Facebook and our website, because the questions keep coming on, can we get access to this webinar? So we'll get it to you, don't worry. And if you don't hear from us by the end of the week, do send me a message. Okay, thank you. Thank you, guys.
Thank you. Thank you.